talk about vestibular rehab and central vestibular syndromes.
Hi, good morning, guys. Okay, I'll try to be exciting because these are nice dry topics. A little bit about myself. I am a physical therapist. I have been working for 31 years, 28 of them here at Moss Rehab. 21 of those on the brain injury service, inpatient, outpatient, management, you name it. In the course of doing that, I noticed that a lot of my patients were dizzy and wanted to know more, and I got really lucky because about the time I started looking for evidence, there actually was some good evidence. Mostly originally coming out of Florida and then Atlanta, Georgia, where Susan Herdman and then husband Ron Tusa were doing a lot of research and seeing a lot of vestibular patients. He is a neurologist, she is a physical therapist, and they provide certifications. So I've done 3 of the 5 certifications that are offered in vestibular evaluation and treatment, cervicogenic dizziness, and an advanced vestibular certification. So that's me, and that's where I got interested in doing this. And actually, if anybody's on the first floor right now, there's a lady I saw on Friday who is presents with a lovely unilateral hypofunction and not a central problem. So I'm really fascinated. She got admitted to the hospital. Good for her. But you know, you are found out. People like that too much. So basically, let's talk a little bit about central problems. So it has been estimated that 7 to 45%, which is a wide range, of people reported to have a central vestibular problem. There are multiple causes of central vestibular disorders, and the symptoms will include a wide variety of unpleasant things like dizziness, nausea, vomiting, imbalance, gait abnormalities, and gaze instability. So these patients have trouble looking, moving around, doing what they need to do. So the objectives for today are to describe the symptoms and presentation of common central vestibular disorders, describe clinical findings of common central vestibular stroke syndromes, and then discuss treatment options for patients who have central vestibular disorders. So some of the neurologic symptoms you're going to see is extremity and facial weakness, confusion, headache, extremity or facial numbness, dysarthria, incoordination, and visual deficits. Lateropulsion, subjective visual vertical problems, ocular tilt reaction, and other oculomotor anomalies. So we're going to talk in a little more depth about those particular deficits. So lateropulsion is falling or leaning to one side. Lesions in the lower brainstem, you'll have an ipsilesional lateropulsion, and lesions in the upper brainstem, controversive lateropulsion. So the patients will either fall towards or away from their lesion depending on where it is located in the brainstem. These patients have difficulty with balance, functional ability, self-care, ADLs. Just getting around, they're really leaning to one side or falling over to one side. Subjective visual vertical. So this is your perception of vertical. It has been estimated that patients post-stroke, and not just vestibular stroke, but stroke in general, have an altered perception of where vertical is. And this makes it very hard to get around. Again, lesions in the lower brainstem, you're going to have an ipsilesional problem with subjective visual vertical. And if it's in the upper, it's going to be controversial, or contralesional. Also, lesions in the thalamus or cortex can cause subjective visual vertical and could be in either direction, all right, and not so lesion specific. So how do we assess for this? Well, there's a very expensive computerized testing system that costs $30,000. But thanks to Swerkel et al., they developed a bucket. And if you come into the outpatient gym, you will see my bucket. It's from Lowe's. And for $10, I made a device that has the same sensitivity and specificity as the $30,000 computerized version. So they did a nice little study where they tell you how to make one, and they tell you how they did their validity testing on it. But basically what it is, it's a plastic bucket. Again, I use a Lowe's bucket. Inside there is a piece of glow-in-the-dark tape. It is aligned vertically with a protractor that is taped to the outside of the bottom of the bucket. And there is a piece of embroidery thread with a fishing weight on it. And that's it. It's simple and easy. You present it to the patient's face. You do not let them hold it. And you present it off axis, and you turn it slowly, and you ask them to tell you when the line is vertical. And you test on both sides. And what we're looking for when we use the bucket is a 2.5 degree or less difference from pure vertical. So they can score anywhere from 2.5 to 0 on either side, and that's considered normal. If they score off, and some of my patients will have score 15 degrees on one side, they're going to have a problem. So, well, you know, again, they're going to have problems with balance, with functional ability, with self-care, with ADLs. It's hard to negotiate and move around when you are off by 10 or 15 degrees from vertical. So the patients are able to use gravity the way they used to tell them where vertical is. All right. Another thing we're looking for is ocular tilt reaction. Okay, so patients who have a problem with ocular tilt will have a lateral head tilt, a skew deviation, so that's vertical misalignment of the eyes, will be depression on the downside eye, so if their head is tilted to the left, their left eye will be down, the right eye will be up, and they will also have torsional rotation of the eyes towards the down ear. So all of us have an ocular tilt response. That is normal. So if I tilt my head, the whole room doesn't go with me like this. I still see everything vertical related to gravity, because when I tilt my head, my eyes toward in the sockets away from the head tilt, and the bottom eye moves up. And that enables me to see straight up and down. But if I have a lesion anywhere along the utricular pathway, okay, running through the brainstem and up, I'm going to have a problem. I may have a problem with ocular tilt. And so my head will assume a position that makes sense to me as to where vertical is. And I'm no longer responding to gravity. And since Earth has gravity, it's a good thing if we respond to the vertical pull. These patients will also have problems aligning themselves correctly to the surface they're standing on. So these are patients for a cheap and dirty test. I can put them on a ramp in the gym. There's a couple of ramps that go up to some of our robots. I can just stick the patient on there and just tell them to close their eyes. And if they're standing on a ramp and they can sense where gravity is, they will realign their body in relation to gravity. But if they can't perceive gravity and use that information to help them be vertical, they'll align themselves to the surface they're standing on and they will fall. All right. So, lesion site and central vestibular signs. If the patient has a lesion in the lower brainstem and periphery, they may have ipsilateral lateropulsion, ipsiversive subjective visual vertical, and ipsiversive ocular tilt reaction. Upper brainstem, contralateral, controversive, and controversive for the same thing. So this is just a summary chart. For the thalamus, if you have a lesion in the thalamus, you're going to have contralateral lateropulsion, ipsiversive or controversive subjective visual vertical, and ocular tilt reaction. Abnormal ocular tilt response would be uncommon. And in the cortex, lateropulsion is not seen. Subjective visual vertical could be ipsiversive or controversive, and ocular tilt reaction will be uncommon. So let's talk a little bit more about skew deviation. So here's a bad one. This is what you will see in room light. So this is when you look at a patient and whew, it's got wonky eyes. So something is wrong, and it's a vertical misalignment of the eyes without an ocular pause. So this is coming from the brain, not from the eyes. And it is caused by brainstem damage. Other oculomotor abnormalities that you may see, abnormal spots. So that volitional quick eye movement from one target to another is impaired. It's either dysmetric or they're over the target, they have to jerk back, or they're taking a lot of movements to get to the visual target. Impaired VOR cancellation. So for the vestibular ocular reflex, that's that reflex that enables us to maintain a focus and gaze when we move our head. Normally, it has a gain of 1. So for those of you who are engineering majors before you went to medical school, That is a ratio of output over input. So when a normal VOR gain of 1 is when I move my head in one direction, my eyes will move in equal and opposite amount in the opposite direction. Same speed, same amount. All right, and that is very necessary for negotiating your environment, being able to move and see. If you don't have a VOR, then what happens is every time we move our body or our head or our eyes, everything moves around and we have to wait until everything stops moving before we continue doing what we're doing. So that's the VOR. The VOR cancellation is the ability to cancel that reflex if we need to. Otherwise, every time we turn our head, our eyes are going in the opposite direction, and that wouldn't work. So sometimes you need to be able to move your eyes and head together in the same direction. And that is the ability to cancel the VOR. With patients who have central vestibular stroke, they will have problems canceling their VOR. So what we see when we do testing. When I do testing for VOR, I tip the patient's head down about 30 degrees because their horizontal canals are tipped back about 30 degrees. So to get their canals in the plane of motion, I tip with the down. I'm going to move their head from side to side. I ask them to look at something. I usually use my nose. And I test for VOR. I should see nice ability to maintain gaze focus on my nose. When I want to test VOR cancellation, I have to move too. So usually it's good to do on a rolling stool because it's always rolling thighs, but the patients here, I am moving with them from side to side, and I want to see that they can keep their gaze on my nose. I test it in the vertical and horizontal planes. When I do this test, I am looking for the ability, again, to keep the eyes on the now moving target. If they can't do it, what I will see is a lot of corrective saccades, a lot of catching up, a lot of attempting to stay with the moving target, which in this case would be my nose. And again, I test in horizontal and vertical planes. Also may see direction changing nystagmus. So I will test gaze evoked nystagmus in a horizontal and vertical plane, and I'm looking for direction changing nystagmus. I bring the patient out, I hold him there. Oh, there's a little nystagmus in his beating to the left. Okay. Then I bring him over here. Oh, there's a little nystagmus now beating to the right. So direction changing nystagmus is the sign, central sign that we're looking for. Downbeating nystagmus also always assumed to be a central problem unless proven otherwise. And I may see saccadic smooth pursuit. So even those saccades and smooth pursuit will have some degradation with age, which is considered normal. Here we're talking about big problems with saccadic control and also a very jerky pursuit when trying to follow a target. Okay, so there was a very nice article by Kata that was published in the Stroke Journal in 2009 that looked at how can we tell that someone who comes in an acute vestibular crisis or has acute vestibular syndrome presents the emergency room with nausea, vomiting, dizziness, vertigo, imbalance. How can we tell that they're not having, are they having a stroke or is this an inner ear infection? So they did a nice little study with 101 subjects, and basically they looked at which simple clinical testing could be done that would enable us to tell whether the patient's having a stroke or having an inner ear problem like a vestibular neuritis. And what they found was if they did a test, and they call it hints to INFARCT, so hints standing for head impulse is the HI, it's a head plus test, and is for nystagmus, and they're specifically looking for gaze evoked direction changing nystagmus, and TS in hints for test of skew. So if the patient comes in and they have a presentation that looks like stroke, it could be a peripheral vestibular neuritis, it's acute. Someone who's having a stroke will have a normal head thrust test, all right? They'll have a normal head thrust test. They'll have direction changing, gaze evoked nystagmus, and they will have a vertical skew deviation. And this study found it was 100% sensitive and 96% specific for diagnosis of stroke. So basically, they proposed using a 3-step bedside oculomotor exam because it was found to be much more sensitive than early MRI diffusion-weighted imaging in diagnosing vestibular stroke. So that's a nice little handy-dandy test you can do. So I'm looking for, if my patient is complaining, I'm looking for a skew deviation. I'm looking for a head thrust test. In someone having a stroke, we should not have a positive head thrust test. And again, they'll have gaze above nystagmus. It's probably going to be direction changing. And they'll have a subjective visual vertical that's deviating towards the affected side approximately 7 degrees. So remember, if I use my bucket, it's 2.5 degrees. So that would be significant, all right, if they had a 7-degree deviation. All right. When I look at my patient's eyes for, and they're complaining of dizziness, and I'm suspicious that it's a central cause, they're probably going to complain they're constantly dizzy, and it's less likely to be provoked. Or they have a baseline level of dizziness, and I can make it worse by making them move. Sometimes they have their eyes shut. They don't want to open their eyes. They'll have jerky pursuit. They'll have abnormal saccades. Does it drift to one side? Is it dysmetric? Do they have an outflow tilt reaction? Is there presence of downbeat nystagmus? Do they have impaired VOR cancellation? Of course, I'm a PT, so an exam of, I'm going to do a sensory exam, I'm going to look at pain and temperature. Of course, I'm going to do a motor exam, tone, coordination, gait, functional mobility. I'm going to take a social history, and I'm going to look at what their roles and responsibilities were premorbidly and what we need to get them back to doing. Let's talk a little bit about the vascular supply and associated disorders. So it's the vertebral-basilar artery system that is supplying both the peripheral and central vestibular structures. Vertebral artery supplies the posterior inferior cerebellar artery, and that supplies the inferior cerebellar hemispheres and the dorsolateral medulla. The basilar artery supplies the pons and the anterior inferior cerebellar artery. The ICA supplies the peripheral vestibular labyrinth via the labyrinthine artery, and the ventrolateral cerebellum and the lower 2/3 of the pons, including the rostral 1/3 of the vestibular nuclei. So the vestibular nuclei are located in the brainstem, and they're responsible for postural control and also control of eye movements. The thing about the labyrinthine artery is this: for the peripheral apparatus, the semicircular canals and the otoliths in the inner ear, this is the only blood supply. So yes, you can see someone who can have a stroke in the labyrinthine artery, and they will have a complete loss of function of the peripheral apparatus on that side, and they will be deaf. So you can see that it is the only blood supply to that those inner ear peripheral structures. So, what are some causes of central vestibular disorders? Vascular. So you can have vertebro-basilar insufficiency, cerebellar infarction, anterior artery stroke, also posterior inferior artery stroke, TBI, cerebellar degeneration, migraine, and epilepsy. And we're going to talk about these individually. All right. Okay. So vertebro-basilar artery insufficiency, most commonly due to a vehicle accident. Most common visual symptom is visual field cut, and vertigo is associated with other central signs. So I saw a patient who was referred to us for dizziness. Unfortunately, she spoke Portuguese, which I don't speak, and we did not have an interpreter. So luckily, her husband was there, so we could ask her some questions. She was in her mid-50s, was complaining of dizziness. When we started asking her and her husband more questions, found out that she had double vision, she had drop attacks, she had dysarthria, she had dysphagia. So she had 4 of the 5 Ds that are present for vertebro-basilar artery dissection. The patient was complaining of balance problems. This is a red flag for us. We sent her out, and she had a vertebro-basilar artery aneurysm on MRA. So we're always on the lookout because she did not have a history of trauma prior to her complaint of dizziness. But we're always on the lookout just in case, because that vertebral-basilar artery test that we get taught in school, and I'm assuming you guys get taught to do this, is not sensitive or specific. There's no evidence. I don't want to put somebody in that position, leave them there for a minute while I watch their eyes and make them have a stroke. So I do tend to do that test in sitting and not for very long, and rely on history and other central signs. All right. So let's talk about cerebellar infarction, and we're going to talk first about anterior inferior cerebellar artery stroke. This is the first branch of the basilar artery, and it supplies a lot of important stuff, like the lateral inferior part of the pons, middle cerebral peduncle, floccular region, anterior petrosal surface of the cerebellar hemisphere. It has a very varied course and vascular supply, and there is a reciprocal relationship between vascular territories of ICA and PICA. So, and sometimes people have abnormalities in vascular tree, as you are aware, and there can be some overlap. But what's the patient who has an ICA stroke, which is more unusual to see than PICA? Vertigo, imbalance. They have an altered perception of verticality. Remember, we talked about that before. Loss of pain and temperature, ipsilateral on the face and contralateral on the body. Hearing loss and tinnitus. So one of the differences between PICA and ICA is the hearing loss. With PICA, hearing is spared, and with ICA, hearing is lost. So they can present similar to a lateral medullary infarct. They will have direction changing gaze of nystagmus, and this is a result of floccular damage. They have unilateral hearing loss, ipsilateral, and ipsilateral facial weakness. So for PICA, okay, this is the largest and last branch of the vertebral-basilar artery. It's supplied inferior posterior surface of the cerebellar hemisphere, adjacent to occipital bone, ipsilateral part of the inferior vermis, and inferior portion of deep white matter only. It does have some variations, and sometimes it is absent. About 20% of the population will have one, so then the ICA does it for you, all right? And that can be a problem if you have damage to your posterior circulation. I treated a gentleman last year, a very successful gentleman in his late 30s. He was at a dinner party, the wind blew the door shut, they were on a high porch without steps going down to the backyard. They couldn't get back in the house. He got the great idea that he should dangle over the side of the porch and jump down and then go around the front and let everybody back in. But once he got over the side, he realized he was kind of high up. So he dangled and let go. He landed, he hit hit the ground with his feet first, broke both of his calcaneae, and then sat down hard and then fell back and struck the back of his head. Went to the emergency room where they evaluated him, fixed his feet up, and sent him home. The next morning when he woke up, he was feeling a little sluggish and didn't want to get out of bed. His wife got on the train to go downtown to work, but she was nervous about him, so she called a neighbor and said, "Hey, can you go in and check on him?" And she said, "His car's still in the driveway." The neighbor looks out, car's still in the driveway, goes in, there he is, having a stroke, and goes into the hospital. He had traumatized his posterior vessels, and unfortunately, unbeknownst to him, because why would he know it, he did not have a PICA on one side. He was born that way. So he only had one, and it was supplying both sides. So when he banged the back of his head, he damaged the lumen of his PICA on the opposite side. So he had a rather spectacular stroke with a much more significant presentation than one would normally expect to see with a PICA stroke. So don't be a hero and jump off the high porch in the back. So what symptoms will you see? This is the most common cerebellar stroke, which is fortunate because these patients do very well usually. They have a longer course of recovery, usually we say about 2 years, but they do really, really well. They'll complain of vertigo, dysarthria, altered perception of verticality, ataxia, loss of pain and temperature. It's ipsilateral in the face and contralateral on the body, so it's similar to ICA, but no hearing loss. Also, dysphagia, very important, and dysphonia. So these are patients that can have problems with partial vocal paralysis. They can have problems with swallowing that persist as they recover and start really moving around. So what we see with a PICA stroke, horizontal nystagmus, it will beat away from the site of a lesion. You may also see upbeating nystagmus that has some torsion associated with it. Again, this is without doing anything in particular. You're observing this in real life. They have ipsopulsive saccades. Their vertical saccades deviate towards the side of the lesion. And they have ipsilateral horizontal saccades that will overshoot the target and contralateral horizontal saccades that undershoot. And they will have an ipsilateral ocular tilt reaction. So here's a gentleman who has tonic ocular tilt reaction. He has a sustained head tilt, and he has concurrent vertical divergence. Okay, this thing is not working. He had acute infarcts in the middle cerebellar peduncle and lateral inferior pontine tegmentum. All right. So what we'll see on the same side, we'll see hemiataxia, dysarthria, lateropulsion, dysdiadokinesia, Horner syndrome, and you know what that is. There's a reminder, they'll have unilateral ptosis, meiosis, anophthalmos, facial anhidrosis. All right. So again, recovery post-infarction is better than post-hemorrhage. Upon discharge, 2/3 of post-infarction patients achieve functional independence as measured by the FIM. On follow-up, 83% were scored independent on the FIM by telephone interview 3 to 41 months after their stroke, and only 50% of post-hemorrhage patients had a FIM score of minimal assistance. So again, infarction is better according to a study done, it's published in Stroke, on functional recovery. So just a review, this comparison, what you will see in both ICAs and PICAs is the competitive vertigo, lateral pulsion. They have unusual visual illusions, facial numbness, limb numbness, disequilibrium, and coordination. We'll see nystagmus, decreased facial sensation, ipsilatery, dissociated sensory loss, to pain and temperature contralaterally. They have Horner syndrome, ipsilateral ataxia, and gait ataxia. They'll have abnormal imaging, obviously, spontaneous nystagmus, and decreased hearing. Damage to the fifth nucleus, spinal tract and vestibular nuclei. But in PICA, you'll see hoarseness. Again, they can have some vocal cord paralysis. They'll have saccadic lateral pulsion, skew deviation, saccadic lateral pulsion again, and then they have damage of the nucleus ambiguous and dorsal. The big difference between PICA and ICA is tinnitus, hearing loss, and facial weakness. And they may also have a gaze palsy. If we do lab testing on someone who's had an ICA stroke, we do balance function testing in the EMP lab, or we do caloric testing, they're going to have reduction of caloric responses ipsilaterally, so on the same side of the lesion. So there'll be damage to the inner ear, 8th cranial nerve, 7th cranial nerve could be with facial paralysis, and 8th cranial nerve root entry zones, 6th nerve nucleus blockers, and cerebellar peduncle. So I saw a gentleman 2 years ago who was very lucky because he was out deep sea fishing and he stroked on his way back in, so he survived. So he had a PICA stroke. He presented at the dock with a really bad pain in the back of his neck, dizziness, vomiting, nausea, taken to the hospital, worked up. He'd been a professional competitive weightlifter, and I don't know how much you know about weightlifting. I learned a lot of that. I didn't realize there were some competitions where he was just a bench presser. That's all he did. So they just set up a bench and just bench as much as you can. And of course, he took steroids for years before. He had stopped about 12 years prior because he destroyed both of his shoulders from doing bench pressing competitions. So he had stopped the steroids. He was a very large guy, big, muscular, small head. And when he was in the hospital, his neurologist was saying, "Oh, it's because you did all those steroids and that weightlifting, and that's why you had this stroke." Well, it was 12 years before, so not sure about that. So Anyway, he was in his 40s. He had the stroke. He presented to me with a very wide base of support. He could not see clearly. If you look at me, he'd say, you know, I see 5 of you. And they're moving all over the place. Shutting one eye didn't really help him. When he walked down the hallway, if I had him walk with his head in the middle, he was with a wide base of support, very ataxic, slow gait, very unsure of himself. If you asked him to tilt his head or turn his head to his intact side, he would narrow his base of support a little bit. He could walk a little bit faster, so he could tap into his vertebral spinal reflexes and improve his postural set. If I turned his head towards his stroke side, he would completely lose his balance and stagger all over the place. He was a nuclear med tech in a hospital in New Jersey, and when he would look down, he would see 3 or 4 extremities, so he would have had a hard time going back to work, placing a line for patients for testing. So this was a concern for us, could not see well. We got sent out to neuro-ophthalmology, prescribed prism lenses, which really helped to control his visual deficits. Continued with therapy. He was complaining he couldn't walk and talk on the cell phone at the same time. He had very short breath. He was convinced it was a flavix. I wasn't so sure about that, but said, let's send you to the ENT and have you have some testing done. Because I know that PICA strokes can have problems with swallowing and control. And here he had partial vocal cord paralysis, which required injection to try to help him with his hoarseness. And he also had to have he had he had problems with epiglottal closure to hold, which was explaining some of his ability to control his breath support. So he had a bougie procedure to take care of his narrowing of his esophagus, to try to help control with swallowing. He ended up having speech therapy to really work on swallowing control for him and breath support. And he did fairly well. He could not go back to work. He ended up going, he also used to own restaurants and bars, so he went back to doing that and could no longer work as a nuclear medicine tech. He went back to driving. He walked without assistive device. This is also somebody who, when he would lay down at night to go to sleep in bed, he would feel, these patients have motion sensitivity problems, so he felt like he was turning end over end in the bed. It was a very unpleasant sensation. So he would sit on the floor. It was harder. So he could feel the floor underneath him. He also had a classic presentation where he had loss of pain and temperature on one side of his body, and loss of proprioception on the other, and he was always hot. So he wore shorts and a t-shirt no matter how, if it was wintertime, he'd be outside in shorts and t-shirt. He had problems with his sweating on one side versus the other. But he was able to go back to running a restaurant. So he also fixed up vintage cars. And he had an alligator, or I forget what it's called, alligator or crocodile. It's a thing on wheels that they spin in all directions. You can slide into a car. And he made a mistake of going under his car one day on that, and he couldn't figure out how to get out because it was too much motion. And remember, he couldn't lay down in bed because he felt like he was turning. So one of the exercises that we did with him was he brought in his alligator, and I dragged him around on the floor of the hallway to get him used to direction changing when he was laying down. The other thing we did was work on getting him to realize when he's laying down that he's not turning. So you can do almost like a relaxation technique that you do with someone who was having trouble falling asleep or who was anxious. You do the same thing with motion. So I want you to close your eyes, you're laying down, we get started in an incline of 30 degrees, and then slowly get you more flat. And I want you to feel your feet on the bed. And these things work for these patients if you kind of walk them through it and get them to practice eyes open, eyes closed, so that you can not have to sleep on the floor. But these are some of the things in therapy that we would do with them. So let's talk about traumatic brain injury. All right, so there's different types of categories of traumatic brain injury that we talk about that can lead to some vestibular problems. So there's the classic loud concussion. These patients may have sensorineural hearing loss and balance. We also have BPPV with the non-position vertigo. and ataxia. This is probably the most common vestibular injury due to TBI. You will see this with soldiers coming back from Iraq and Afghanistan from blast injury. So those concussive blast waves that, if you're unfortunate enough to be near an IED, can cause a lot of concussion. Skull fracture. If someone has a skull fracture that extends into the petrous portion of the temporal bone into the internal auditory canal, they can develop a unilateral vestibular hypofunction or bilateral vestibular hypofunction. They can get BPPV, and it can be multi-canal BPPV, so it doesn't have to be just one canal on one side. It could be bilateral and more than one canal. They can be very complicated to treat. They can also have a conductive hearing loss. Again, blunt trauma to the occiput temporal parietal areas. If you faint and fall backwards, or somebody sucker punches you and you fall backwards and hit your skull on the floor, your occiput stops, and the rest of your skull will collapse around that bone, and that can cause a basilar skull fracture that will extend up into the temporal bone, into the internal auditory canal. And there's a lot of good stuff in internal auditory canal, like branch the facial nerve, there's nerves in the medius, it's vestibular nerve. These can cause a lot of problems with both dizziness, balance, hearing, gaze stability. Brainstem hemorrhage will have oculomotor signs, complaints of vertigo, perception of tilt, like this. Let's bring your head back up this way, Bob. Now my head's tilted to the left. So there's a perception that this is the correct position and upright is tilted in the other direction. Brainstem hemorrhage, that's where the vestibular nuclei are located, so postural problems and also visual problems. Labyrinthine hemorrhage, you can develop a post-traumatic hydrops. So you will see some patients who have post-traumatic Meniere's disorder, so they'll have a feeling of oral fullness, tinnitus, they'll get spontaneous, vertiginous episodes, where nausea, vomiting, the world is turning around. They can have acute vertigo, hearing loss, and increased intercerebral pressure, fluctuating hearing loss, ataxia, imbalance. They may also have a perilymphatic fistula, where there's pressure changes, loud noises can cause a patient to have a quick bout of vertigo and dizziness with some nystagmus caused by a third window in the inner ear, so a hole in the inner ear that doesn't belong there, which sometimes needs to be surgically corrected. All right, so cerebellar degeneration. Okay, so some causes of vestibular problems, cerebellar degeneration, Friedreich's ataxia. Again, this is a disorder of spinocerebellar pathways, posterior column, and pyramidal tracts. So they will have problems with visual cancellations, the ability to revise and heads together and still see clearly, smooth pursuit, and saccades. Olivopontocerebellar degeneration, cerebellar cortical atrophy. So patients with cerebellar degeneration often have symptoms of vestibular, ocular, and postural control problems as well. Okay. Paraneoplastic syndrome, I will see patients with this. So again, you have rapid and progressive cerebellar degeneration due to the autoimmune response of cells in the cerebellum, particularly Purkinje cells, responding to what's going on with cancer located somewhere else in the body, like small cell lung cancer, breast cancer, ovarian cancer, and Hodgkin's lymphoma. And these patients complain of dizziness. It's usually constant. It may become exacerbated or increased with position change or head and eye movement. Their balance is off as well. So migraine. Migraine vertigo will present with and without headache. So someone who has a long history of migraine may also present with a non-headache vertiginous complaint that gives them vertigo, complaints of dizziness, motion sickness. It may look a little bit like BPPV because they don't like to move their heads. If you've had migraine, your head feels like a very painful boulder and you don't want to move it. So those patients will hold their head very still. So when they change positions, they say the dizziness gets worse. What you won't see is the classic BPV presentation, torsional nystagmus, beating towards the downside ear. That goes away. So these patients, once they have this dizziness, it tends to be a low-level, constant dizziness. It's bothering them all the time. They don't like to move. Sometimes they come into the clinic wearing sunglasses and a soft collar. Yikes, we have to get rid of that and get them to move. They'll have classic migraine symptoms like photophobia and phonophobia. They may have aura. And they may have a significant headache history, but once, if it's a female patient and she's past menopause, the headaches might be gone, and it just might be dizziness. You know, I get these spells of dizziness. It can be food trigger related. How do we treat that? Well, if they're not seeing a neurologist for a headache, we send them to a neurologist who specializes in headache, because the medications that you use for migraine, for headache, also treat migraine vertigo very well. The other thing is to get them moving. We want these patients to move. So they have to have some kind of exercise. They have to move their head. They have created some weird behaviors, like I only have to do the dishwasher when I look up, I never look down at the dishes. So we have to get them to move the way you would normally move. They need to exercise. If they have a food trigger, and it's estimated about 10% of migraine, there's a food trigger associated with it. You can educate them about looking at their diet and seeing, are you eating a lot of hard-aged cheeses? Are you eating a lot of chocolate? Things like that. Kind of go through, talk to them about it, and have them sort of keep track in a diary of when they get their symptoms. But again, treatable with medication and a brief course of therapy, some education so they know what's going on. All right. So epilepsy. All right. So choral vertigo is rare. This is unusual. And they may have subjective visual vertigo if there is impairment of the parietal insular vestibular cortex. So central vestibular disorders present with typical peripheral vestibular symptoms. So acutely, you're going to see the same things: dizziness, nausea, complaints of vertigo, imbalance, gait abnormalities. But someone who's having a central problem will have other neurologic signs. So maybe they'll have weakness, confusion, a headache, numbness, dysarthria, incoordination, visual deficits. So the goals for patients with central vestibular dysfunction are to get improvement in symptoms and function for patients with central or mixed peripheral and central vestibular dysfunction. But it's not as good as patients who have just a peripheral problem, right, as measured by functional outcomes. There are no random controlled trials of the efficacy of PICA in the treatment of individuals with central vestibular disorders. All right. So what else can be done? Well, medically, there are drugs that can be prescribed to suppress nystagmus. So gabapentin, lamivudine, baclofen can suppress it, and they have side effects that are associated with them. So it's there's some drawbacks to prescribing them, but for patients who are acutely post vestibular or cerebellar stroke, vestibular suppressant drugs or nystagmus suppressant drugs may be needed so the patient can participate in rehab, with the goal that we will wean them away from those drugs, because if you're suppressing the vestibular system, we're kind of getting at the mechanism or suppressing the mechanism that we want to try to tap into in rehab. But if the patient can't open their eyes or sit up without vomiting all over the place and they're miserable, we're going to have to give them something. So there are drugs you can give. Meclizine is far and away the most popular medication, and all my patients are on it. Again, it's an antihistamine. What it does is suppress the vestibular system. If the patient is, if it helps the patient, then, we might talk with the doc about gradually moving off of it. Again, if they just have BPPV, maybe they know, and we'll try to get them off of that right away, so that's not the treatment. But for someone who has a central problem, sometimes we need to have medication on board so the patient can at least start moving around, because they are miserable. They feel really bad. Other drugs you can give are anti-emesis drugs like ondansetron, granisetron. I've never seen that one, and also Reglan. But I see, above all, I see Zofran, and so for some of my patients, the quick dissolving under the tongue Zofran is the best. They love it. So what do? We do functional mobility training. We do balance. We have a smart Equitest system here at Moss. So we can test balance, we can test sensory and motor components of balance, and we can also do treatment on the test, the same platform. We can also do gaze testing and dynamic visual acuity testing with the system. So you can get a percentage of function comparing right side to left side. It's pretty great. So we're going to do progressive challenge. We're going to do dual task performance. We're going to ask the patient to do manual tasks while they're balancing. So I may ask them to walk and juggle a ping pong ball on a paddle. Cognitive overlay. If you work with me, you better know your state capitals because I will ask you while you're trying to stand on one leg and toss a ball from one side to the other, what's the capital of California? And nobody knows the capital of New Jersey around here. Everybody thinks that it's Camden. So I'm going to make them work. Their balance will be worse if I ask them to do a manual task or if I ask them to do a cognitive task. And if they're getting good enough, I will ask them to do a manual task and a cognitive task at the same time. All right. And sometimes the other patients help each other out by yelling out the answers. We'll also do gait training. So assistive devices. When the patient comes into the gym, if I can treat them without any assistive device, I will. Because the goal will be to get them away from it. But I want them to be safe in the community and at home, because I'm an outpatient therapist, so I'm going to advise them to kind of continue with their assistive device until we feel they're safe. But we're going to take them outside. We're going to have different environments. It will be harder for them in our gym, which is really scary and busy. When they start in a quieter room and work up to a busier one, we'll change the surface that they're on. Of course, we'll address strengthening and stretching, any tightness, and the bread and butter of physical therapy. And also, we're going to do some vestibular adaptation exercises. We're going to start with one exercise. They might have to start in supine if they're very impaired, or sitting. The goal for me is to get them into standing as quickly as possible. So we're going to work on trying to adjust that VR gain back to 1. Okay, so they're going to do gaze adaptation exercises. In the horizontal plane, they look at a target, they move their head from side to side, about 20, 30 degrees to each side, looking at a target and moving their head. The target should remain clear, in focus, not double move around. And that's how they know they're doing it. They're keep pushing that head speed, and they're going to move very slowly. We're also going to work on posture. So if I have the patient standing, where are their feet? Together, one foot in front of the other, standing on something squishy or something that's moving. All right, so that I'm challenging the vestibulospinal reflexes at the same time. All right, I will also do convergence training. I'm sure that Steve talked to you about convergence training. That is the one vision therapy that has good random controlled trials with large N's that were done that show that you can train convergence and you can improve it. So we have a bunch of different things we can use. We can use timer lifesaver cards, or this is a rock string that this woman is using. We can also use barrel cards. And the goal is to get the patient to notice that they see double and then try to fix it by trying to converge their eyes. And we can do those exercises, again, changing the position that the patient's in. And also, I can ask if someone is doing a rock string exercise and doing pretty good. Okay, good. So now turn your head from side to side and keep the B that you're looking at single. And they'll also see double front and back, so they'll see an X formed by that string, and it should go right through the middle of the B. So we will do convergence training. I also refer them to neuro-ophthalmology in case they, need optics. So if they need to have prescribed vision, I will refer them to Steve to see for vision therapy. I'll refer them to neurooptometry. We send a lot of our patients to the Eye Institute so that they can do some vision therapy and improve their use of their eyes functionally. I may also have to teach vestibular substitution strategies. So for patients who have a central vestibular problem, I'm going to teach them to use alternative sensory systems to substitute for their vestibular impairment. if it's very large. And it may be something that we teach and then fade as they start to do better. So I may have them use somatosensation or vision to help them. If I can get them to substitute with something else. They'll already be over-relying on their vision because that's what everybody does. As soon as they start to feel off balance and dizzy, they're like, I just stare at something and I focus on it, and that's how I can get from one part of the room to the other. And sometimes we have to break patients of that habit. I don't want you to stare at something. I want you to be able to move your eyes and head and move around. Most people can get down the hallway without staring at the exit sign at the end. So I may teach that. I may teach them to move more slowly. I may teach them to perform a lot of little saccadic eye motions to look at something over there or move their eyes first and then turn their head. It depends on what the patient has trouble with, what they're going to do, but I may have to get some movement substitution or some sensory substitution to help them to be functional and safe. So, in conclusion, sentinel vestibular stroke syndromes are treated with a combination of drug therapy, PICA, OT, speech, inpatient, outpatient rehab, vision therapy, optics. The recovery is slower, and full recovery is less likely to be expected in patients than those who have peripheral vestibular disorders. That was very quick. Thank you very much. And I end with a picture from Dr. Seuss, who looks like he might have had a vestibular problem at one time, because this is from your only old ones, and that looks like a horrible balance function test that he might have had to undergo. Does anyone have any questions? Okay, thank you very much.